frame. So we have lots of time for some discussion and questions. I believe there's a microphone. According to Neil, we have to speak into a microphone. I was listening to you, Neil. So does someone have the microphone? Okay. And I see a hand going up for questions. I'm going to ask you because as Neil was good at explaining, we are a community of people, and it would be nice to know who's speaking. So if you could introduce yourself, and if you have an affiliation, that would be great to know. If not, introduce yourself and then bring your question forward. It can be to the full panel, or it can be to individuals. Did you have a question? So one here at the front table, and over there.
My name is Janice Alton, and my affiliation is with Canadian Voice of Women for Peace. I have a question for the last speaker, Matt. Is it? In 1993, the UN hosted its second global conference on human rights, and one of the outcomes of that conference was a statement that was agreed upon by all of the states present, as far as I know, which said that human rights trump cultural differences. And so this comes up repeatedly now. I follow the work of the Commission on the Status of Women, and there are states members within that commission that often try to block statements and progress. So this language we are reminded of this important 1993 language.
Well, just to respond, and I actually probably want Carol to respond too to this question if she has a moment. I mean, it's a great comment and question, and I fully agree with it. I fully agree, and I actually think if we went in and had more time, I would love to talk about how I think human rights should impact the way we think about even the issues I presented. I think one of the challenges is that in practical terms, trainees often go abroad and find themselves in these situations and have no idea about this, and it wasn't necessarily thought of in advance. So, for example, the focus group quote that I showed, where the women had been beaten, in that focus group of trainees, none of them actually recognized or described it as a human rights issue. It was only after I, as the moderator, waited and waited and waited for them to, I was just begging for them to say something about human rights, and I said, well, that situation, wow, that sounds a lot like a human rights issue. And then a light bulb went off. And so this connection between, I think, what is firm footing in human rights and the trainees that experience, that connection somehow needs to be made better. And I would love it if Carol commented on that too, if we could bring her in.
Well, I think this is exactly the kind of concern I have as well. I mean, how do you really, how do you move ahead? And there is the whole progressive realization part of it, which in a way sort of applies, I suppose, that you could, but not to some of the obligations, but particularly, I guess, to how do you realize, how do you help these rights to be realized in a developing country setting or where you're a stranger? So maybe you need to think a little bit about that. But also, I think that the type of research we do should be looking at these questions more. So really, not just, as I was trying to point out in the presentation, not sort of taking a more comfortable position and saying, well, this has to be the case, or just affirming that human rights trumps everything else, which it does. But in real, as Matt said, in the real world, unfortunately, we're not seeing anything like that. It even seems to be regressing. So I think I feel also as women that we need to be somehow getting together, doing more to address all this violence, war. You know, women don't create wars generally. We're the victims. We're the ones who try to make it all better afterwards. We get involved with the peace negotiation, but we're never there when the whole war. We are starting to be, but it's much more a male kind of thing that we go to war, we get weapons, we do all this stuff. And to me, that's something that we're really missing. That's more the action part of it. That I think, rather than, I mean, for example, your group, I think, is just exactly doing the right thing, because that's one group that actually is talking about this issue. But I think, in generally, we're not really focusing, saying, come on, we have to do something. Mm-hmm. So that's not really an answer, but I think it's a very complicated question. But I think that we need to be looking at it from a research perspective. What does work as well? Like, how did Jane? What did she do? Analyze, is this how she might have done better, or did she do it correctly? So I think that our research needs to be going much more in these directions than just kind of reaffirming stuff that we already know.
And I'd like to just add one piece to what you said, Carol, as well, is the research also, we need to ensure that we're including and inclusive of our colleagues from low and middle income countries. So we know that the research community is starting to grow and to support colleagues in LMICs, but we still have a long way to go. And I would encourage us, as we're doing some of the work that Matt is talking about, to engage our international students, our colleagues from international countries in this work. So I know when we do our pre-departure, it's not it is facilitated often by a Canadian, but in most cases, our team is made up of individuals from other parts of the world to ensure that the perspectives are balanced. And I think we need to keep bringing that agenda forward and ensuring that the voices are truly inclusive. So there's a question here. I know that you had a question over here. Since the mic is close, are you okay? And I saw another hand here, so we'll do 1, 2, 3.
Okay. Hi. Thank you very much, all of you. It's a wonderful panel, and I'd like to see gender equity even on panels. It is 2016, but sometimes there are still all-male panels, so it's good to see 2 women. My name is Dorothy Golden Rosenberg, and I teach about environmental and ecosystem health at the University of Toronto to graduate students. I'm very involved in cancer prevention, so I very much appreciated the comments Robert, on cancer and the issues around cancer and cancer prevention. I work with the Toronto Cancer Prevention Coalition with Prevent Cancer Now, which is a national group. I'm in CAPE, the Canadian Association of Physicians for the Environment. There's no question that we know so much about the environmental links to cancer. I produced a film called Exposure, Environmental Links to Breast Cancer, and one called Toxic Trespass on children's health and the environment. They're all very much related to scientific studies that relate to the proof of what we know from IARC, the International Agency for Research on Cancer, hundreds of known carcinogens. So we know so much about what is causing cancer. There is a lot of activity around these issues. It's not as visible as it might be, and certainly what you're talking about in terms of third world countries is shocking and disgusting. I didn't know how bad it was, that there was so little attention paid to it. I congratulate you on your work. I think that your graphic material and presentation is great, and we need more of that. Have you seen the film Pink Ribbons, Inc.?
Yeah.
Okay, everybody should see that one, because if you want to look at how corporations are manipulating when you show the pink everything. Fortunately, it's not as bad here in Canada. So what I would like to ask you is, what kind of possibilities do you see for bringing in the cancer prevention activities that are going on here in Canada and in the United States and in Europe? Because there is an awful lot and really good research now. I'm not sure if you're familiar with Michael Gilbertson and his recent research with the Halifax group, and wonderful research, really challenging how cancer research is being done today too. So I'd like your comments, and thank you all very much.
Yeah, thanks, that's great. The point about just how dire it is in some places in South America, Africa, can't be underestimated. I mean, the work that Livingston did about the oncology clinic in Botswana is a must-read for everyone, because she really makes the case that it's to the point where patients come into the clinic that you're seeing states of cancer that just do not exist in the global north, and thereby totally refutes what the literature, the journals tell clinicians in those countries on how to act to it. So it's alarming, and it requires a rethink about how we are going to approach the collection of diseases that are qualified as cancer. One of it is that I think that there's such an underwhelming lack of moral attention to it, that there is that prejudice that this is something that's reserved for the affluent, and thereby, if we get it, we will deal with it accordingly. But once we acknowledge that this is one thing on a global health scale that impacts the entire planet without discrimination, then we need to actually have that conversation and say we're all in this together, right? A lot of the conversations that we have in global health, be it with HIV, be it even with some of the gender equity things here, there's a us and over there mentality. And this should be the marker to bring it all together and say we're in this together. What I think is going to need to happen before there's any specific projects or what sort of outcomes we can get to is to have a conversation amongst researchers, professionals, and students to say that we need to have more attention and more advocacy, and I'll say it, militant advocacy against the industries, the environmental factors that are causing these sicknesses here too, right? And to actually bring in the class structures. Why are the poor so disproportionately affected by this? Absolutely. One anecdote I will share is that when I was doing research in Ecuador in 2005, I was working with Cuban physicians there, and we were Cuban-trained doctors, I should say. At that time, in this clinic in the Amazon, it was the only public clinic for about 100 kilometers, 6 consultation rooms, 3 were flooded underwater because someone repaired the foundation and messed up. That doesn't help the cause when you are in a clinic in the Amazon and 3 of your consultation rooms are flooded. The amount of illnesses that coming in there, you just see the usual suspects of diseases of poverty, but there was overwhelming evidence of a cancer outbreak that was going on that had likely to do with the presence of hydrocarbons in the water supply there. And it's something that was battled in court between indigenous communities in Ecuador and Chevron and the government of Ecuador for over 20 years, right? And to me, that was an overwhelming indication that you can have some of the best epidemiological research in the world, you could have the militant advocacy there, but if you take it to litigation in a court, some well-trained lawyers can hold it up for decades, and you get no action on it. So I think that's also part of the conversation, that we can have that knowledge, we can have that awareness, but we have to find a way to put pressure on those who can fund the opportunities, those who can regulate industry, to make sure that this crisis goes away. And I'd, welcome much more conversation with you about how we can get there.
Thank you, Dorothy. The gentleman over here in the nice multicolored shirt.
My name is Rob Alder.
Oh, I didn't recognize you. Sorry, Rob.
Good to see you again. I'm with the Director of Canadian Epidemiology Services, and also am affiliated with Western University of Canada. I have also recently been struggling with Parkinson's, so forgive me if I slouch a bit as I speak. I have several questions. I think I'll start with the one to Matt first. The notion of the model of health promotion that we should use seems to come up from your points. And the insider-outsider model is often referred to as the preferable one. How do we accommodate that model in light of what you've been saying? After that, I have 2 more questions, Shauna.
Okay.
Well, I actually think my first response follows a little bit what Bob has said, which is I'm not sure I like the insider-outsider model. I sort of hope we're in some kind of a transitional phase where we can get out of the inside-outside model and think of a much more we model. one unintended consequence often, I think, of the inside-outside model, if I'm understanding your question correctly, where we're coming from outside from a high-income country to go to a low or middle-income country, is that? That's correct. Okay. Is that, even in Bob's case, in the specifics related to cancer, we sort of assume that our way of addressing cancer or an illness or a problem is the correct way, and we need to export it there. And if we take what Bob is saying seriously, then it's not necessarily the case that the disease is the same there, and so our models won't work. But I think that's an unintended consequence of this inside-outside thinking. So although it's helpful in some ways, and you'll see ethics guidelines framed around these concepts of host and visitor and such, I actually sort of wish we could get past it.
Thank you. Those are good comments. I also want to point out that recently we finished a project with the Red Cross in Liberia. It involved a household survey of a couple thousand households in rural and remote Liberia. And to undertake that fieldwork, we deployed and collaborated with a group from Liberia's Institute for Information Services. But we also worked with them to get volunteers to work in the field and do interviews. And 2/3 of them were male. Of course, this is a household survey on maternal health. How do you deal with that if you're Canadian or American epidemiologists and want to put together a team in the field, and you ask local assistance and you get 2/3 male on a female problem?
Anybody want to?
I think that question was for Carol.
Could you just repeat it, please? I didn't quite catch everything.
Let me put it another way. What approaches can we use in doing research in developing countries, particularly household surveys, to increase the female involvement in the interview team?
Yeah, I think Carol might have comments in the research that the challenge of getting local teams to reflect gender equity and equality in some sense, having female interviewers for a household survey of maternal.
Yeah, I mean, I think it's absolutely essential to have female interviewers, and I think often part of the problem is that we, as foreign researchers, feel we have a limited time frame. We're very, have to get to that goal today. We have to do so many interviews and all that. And I was part of that myself in my research, but I think that I made a special effort always to say we have to have women do this. There's no other way. It's women. And so even if it takes a lot longer, and being really, talking to people, explaining why, and often there's a way. If you understand enough of the culture, or if you talk with people there, female researchers, and the problems that they face, then they'll help you as well. And I think gradually you have to achieve that, because really that research is pretty useless often. When you have males going around just bang, 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 these questions, even females sometimes do the same thing, but nonetheless, women just feel totally put off very often by having a male interviewer ask them about abortion, for example. So your point is really good, but you really have to address it, and whether it takes more time to do so, you just have to do it.
Good point. My last comment is, I think, probably directed to you, Bob. The ecological fallacy and the work that you do with the mapping. I very much am a big fan of medical geography, and I like that approach, and even on a time frame scale, looking at ecological dose response curves and such. What are your thoughts about the ecological fallacy, its role and the limitation of those kind of data, and yet on the other hand, the very powerful influence that those type of data can be? How do we work with that?
Ooh. There's two ways that it can go. the influence that it can have can be, can start really important conversations. But at the same time, I mean, within the discipline of geographies of health and healthcare, there's always importance to take time to look at local, social determinants, political determinants, along with environmental determinants that make the map more complicated the closer you look at it. So, I'm not sure I have a specific recommendation for that, but it's something that we see more introduced into our discussions that, starts a conversation. I don't know if it's one that can conclude it, but it definitely starts it. Yeah.
Thank you very much. A question here. Was there one over here as well? And then I see a hand, Michael, in here. So, we got lots of questions. Neil, I'm begging forgiveness of going over time. Oh, okay. So, Carol, we have 10 more minutes because there's a super long coffee break. This is a good conversation. So there's at least 4 more questions here.
Hi, my name is Afnan Naeem. I'm from the University of Waterloo, finishing my undergrad in health studies and anthropology. Thank you for the panel, that was great. My question is regards to the human rights discussion. So how do we bring the dialogue of human rights to cultures who've been practicing, phenomena for thousands of years and have never heard of the term human rights?
Good question.
I think we're about out of time, aren't we, for questions?
Good try. Good try.
Go ahead, yeah, please.
It seems to me that there are not very many cultures in the world that are not represented by a government that has signed on to the human rights treaties at some point. So to me, that's the background that you have. You have something to always to go back to and say, by the way, here you are. You signed this treaty in 1948, and you really that's a great starting point, because really, as I said in my presentation, human rights are transformative. It can transform things, and I think if we forget sometimes, we get all caught up with all the terrible things that are happening, the abuses of human rights. But that's saying, okay, we have to go back and somehow have a dialogue with those governments. And I think that that's what our politicians should be doing. I think some have actually done quite a lot. But overall, I mean, it's not a helpless situation in that respect, because they do have a history and there is something behind it. So to me, that's a good starting point, and then you try to move forward from that.
Carol, I would completely agree.
Go ahead, Tom.
I'm supposed to be facilitating. I'm jumping in. I used to work in Nunavut as the director of policy for the Department of Education, and I used to use various human rights legislation, both Canadian and international, in helping to move forward the agenda. And oftentimes, people didn't know about them. There's a huge need for education. When people hear the word policy, there is this deer in headlights look that happens. They hear legislation, it's fear, and I think we need to think about knowledge translation of how do we raise awareness of what these tools are and why they're important. So to take Carol's point one step further is we do need to really raise the awareness and think about how do we use them effectively. Bob, did you want to add something as well?
Yeah, I think to your point, how do we, if the question was, bring human rights to places without, it's not going to happen through UN edict, it's not going to happen through government policy, it's not going to happen through an academic conference. Culture, well, that's my geography roots here, no matter where it is, no matter what the practices are, no matter what extreme or non-extreme violations are taking place, within every culture there is always dissent to that culture. There are always activists on the forefront who will challenge the way that that structure works with their own knowledge and with their own resources. No matter where it is, if it's in Taliban-controlled Afghanistan, if it's in ISIS-controlled Syria, there are going to be people on the forefront of that who are defiant against those practices, and they will be the ones that can lead the charge. So our role isn't to bother the UN with some policy of some edict that will show a show of hands. It is about getting ways of support and solidarity for people who are leading the charge. And that's really the only way we've seen that sort of progressive development come.
You know, I think I would only add that the other places we see this, well, first, again, I'm sort of an ethicist. There's the legal rights, legal human rights, and then there's the moral human rights, and they're distinct but related. And we definitely see in a lot of NGOs and programs and health-based programming increasing emphasis on human rights-based approaches. It's its whole own, you know, methodology and theory. And so some programs actually inform their work by human rights, even if they're not necessarily out there directly calling it human rights-based work. The programs are informed by the concepts, some of which are moral concepts.
How about we take the three questions simultaneously, one after another, and then we can respond to them. Sir?
Michael Dworkin, McGill Family Medicine, Palliative Care, PGS, not necessarily in that order. The question is around palliative care. How can we allow Africa to suffer terribly without opioids? When chemotherapy is way out there in terms of expense, I don't expect our treatment protocols to go there. And thank you, Bob, for showing that it doesn't make a difference in mortality. That's very important to look at health economics and the fortunes that we're paying on chemotherapy. That's another moral and ethical question I'm not addressing. Simple question, what about the opioids? To all the panel.
Great. So we'll get over here. Keep that one in mind. It's giving you time to reflect. I meant to do this earlier, but.
I'm Buma Bavana. I'm a family physician in London, Ontario. In our medical school, we have only 3 hours in 4 years to teach cultural competency. And my question is for Matt, because all of our students will have to deal with equity issues in marginalized communities right here in Canada. And the class is divided 1/3, 1/3, 1/3. 1/3 of people who are engaged in global health and very interested, 1/3 who see the benefit through an equity lens, and 1/3 who are looking at their phones the whole time through the lecture. So I wonder if you had any thoughts about engaging that 1/3.
And the last question from Michael.
Michael Clark, Western University. I'd like to congratulate all three panelists. I think it's been a wonderful discussion. And I think some of the conversations are classic difficult conversations that we have had to have. And Matt, I'd like just to raise one issue with you, and I'll challenge you that I don't think the outcome that you had in your focus group with your returnees who were grappling with that problem and not necessarily defining it as a human rights issue, the fact that they had that conversation was in itself an indicator of success. So congratulations on that. I think we have to redefine our criteria for outcomes when it comes to ethics. Thank you.
Thank you for that.
So, exploring the question around palliative care, Bob, did you want to jump in?
Yep. So, I mean, you look at many countries in sub-Saharan Africa, there's complete bans and moratoriums on morphine and opiates coming in. Justified with very, anarchic reasons to say that we can't protect the security of it. We don't want, there to be this big rush on the clinics, and now we've got a, morphine addiction going on. Like, it's not well justified. It's really tied up in international legal rhetoric that can be unchanged, I would say. So there's really nothing physically or universally holding us back from getting pain medication there. But the problem with it, though, is that lack of pain medication in Africa is starting to be justified in some of the literature. Again, back to Livingston's work, where she cites these articles that say, well, pain resistance is higher in African countries. Like, people have written that, right? Who the hell published that and thought it was a good idea, right? And that comes into our cultural competencies, right? Because if we don't really address the fundamental premise of what global health is about, which is making the world a better, healthier place, we can start to justify ridiculous policy with moral absurdities like that. And I think that that's why, even on to the third point, where's the future of global health going with international electives or others? I mean, we need to really move it into a case where if we're still approaching this subject the same way in 100 years from now, we've messed up, right? We want to get it to a level of solidarity and cooperation. And then in that lens, we can get through the politics, we can get through the cultural biases and go from there.
Thanks.
I make maybe a brief comment on the 1/3 of people. I guess by the 1/3 you mean those who can't seem uninterested and are on their phones. A common problem in medical education, probably independent of the topic. You know, I suppose the medical education, med ed part of me really wants to ask, what is it about, in a deep level, what is it about the 1/3 that keeps them disengaged? Why do they think it doesn't apply? You know, oftentimes in those groups we find that the connection is actually made by connecting it to their roles and responsibilities at home and realizing that the ideas of cultural understanding are going to apply, say, when they're on the wards in our hospital and its diverse population just as much as if they were abroad. So, you know, I think understanding really why they're disengaged, I'd love to like interview those 1/3 and understand, and then finding ways to connect with them on in ways that resonate with their current roles and responsibilities.
I have a few reflections on your question on the 1/3. I work in a medical school, which this translates across all of the health disciplines. In Canada, there has been a change in global health, and I'll speak specifically of Dalhousie. We used to have 40% of our graduating class do an international elective in their last year. This year, we had two students. And that has been, you know, a pendulum goes one side to the other. It's eventually going to come somewhere in the middle. There are many factors pressuring, particularly medical students, everything from their residency matching, which is that is the elephant in the room that needs to be talked about, and the impact that that's having on global health. But the bigger piece, which I'm extremely positive about, is that medical students, nursing students, all students in health professions have challenged us to say, I don't actually want to do an international elective. I want to do a local global health elective. And that set of our programs has grown tremendously because they recognize that they don't understand health inequity within their own country, within their own community. They don't understand determinants of health, and they realize they've heard the stories of being put in a clinical setting where they're doing things outside of their scope of practice. So I've talked with colleagues at other medical schools, and they're seeing this shift. There are multiple reasons, and I'm not trying to make it simplistic, but it is a shifting time in Canadian medical schools. The other piece to the 1/3 is I think we need to look at the system that is in place. We often look at the student, and I do think that's an important piece, understanding where the students are coming from. But the reality is we have a lot of faculty development to do. So 1/3 of that is also maybe 1/2 faculty development. We are people who are probably engaged with teaching in some way, shape, or form in our lives. That doesn't represent all of our institutions. And we all have colleagues who don't get the idea of determinants of health and global health. So I think that it's multiple level that we need to be thinking about. And we need to be thinking about the unfortunate thing of accreditation. I mean, the fortunate thing of accreditation. And the fortunate thing of accreditation is it has shifted. In medicine, there are diversity accreditation standards. There are standards on service learning. There are standards that are talking about cultural competency. That was never seen before. This is brand new. We're in a new time. And that is going to influence physiotherapy. That's going to influence nursing. It's going to influence law. They're all influencing each other. So I think we are at a really shifting time of how we see global health. And I think Bob's first comments of what is health, what is global health, is a fundamental question that many of us are exploring to really think in depth and of what it is. And that was why this panel was so exciting today, to hear these various frameworks that we were using. You wouldn't have heard these conversations and had such rich discussions this morning just 5 years ago. So I think we've had a shift. It was nice to have Carol give us the journey from the gender research lens and to remember all the changes that have taken place over the past number of decades. the work we still have to do and not be naive that there isn't work that still needs to happen. And we need to have these conversations and continue them into our plenary. So this was a wonderful start to the morning and to the rest of the weekend. And I sincerely thank all of you for your engagement. Carol, you couldn't see people, but they were nodding heads when you were speaking, and they were very engaged in the conversation. And I can see that there are more conversations that are going to be happening. So I thank both Carol, Bob, and Matt for your commitment before coming here, but also for your commitment throughout and your insight and perspectives throughout the day. So thank you very much to all of you.